The original CheckMate 577 data was presented in ESMO a few years ago, was then published in the New England Journal of Medicine. And the study was basically looking at the role of adjuvant nivolumab post-trimodality therapy in stage 2-3 esophageal and GE junction cancers that had an R0 resection. And what we did in that study was we randomized patients up to about 16 weeks later to get adjuvant nivolumab, and there was certain time points when patients started the drug, but what we saw was a doubling in the median disease-free survival from just over 11 months to 22 months, and the hazard ratio there was 0.69. And then as we looked at longer follow-up, we show a directionally improved hazard ratio, decreasing now to 0.67. And so what we did in this particular data, an abstract, was we looked at the first comprehensive biomarker analysis of this particular study. Now remember, this is the only immune checkpoint inhibitor approved in GI cancers in early stage disease. And so it's a very precious database. It's the largest biomarker database of its size that exists at the moment. And so we did look at the groups and see if there was any specific biomarkers that were indicative of improved efficacy or not. Well, we looked at a variety of biomarkers. So the first ones we looked at were gene expression signatures, and they were assessed by RNA sequencing of the baseline post-chemoradiotherapy surgical tissue. And we looked at 5 different categories: an inflammatory gene expression signature, proliferative, M2 macrophages, endothelial, and fibroblasts. And the genes are available in the appendix, but each of these gene expression signature scores were generated from the literature and from internal Bristol-Myers Squibb's data. And so, and they had previously been shown in an advanced setting in the CheckMate 649 trial to be indicative of an improved survival with the use of nivolumab or ipilimumab. So here now in the early stage setting, we looked at the similar signatures to see if there was a benefit. And we divided those into patient groups into high, medium, or low subgroups defined by signature score tertiles. Then we also looked at a select number of relevant genetic mutations, or gene mutations, should I say, to see if there was a difference in response based on gene mutation status. And then those particular ones we looked at were Notch1, CDKN2A, PIK3CA, and ARID1A. And then finally, we looked at tumor mutation burden and microsatellite instability. We did, however, have a unique opportunity because this is the only phase 3 study that has an adjuvant IO approved post-chemo radiation, to see if radiation could alter the immune microenvironment to make it more hospitable to an adjuvant immuno-oncology approach. And so that was the final data set we looked at. So if you looked at the results, we showed that there was an improved disease-free survival benefit for patients that were inflammatory high and proliferation high, which makes sense because that's kind of the hypothesis that if tumors are hot, they may respond to immune checkpoint inhibitor. And then similarly, we showed if you were the lower the M2 macrophage, the fibroblast, and the endothelial signatures, patients did better. So that was an interesting result, that gene expression signatures may be able to predict for disease-free survival benefit. We did not see that any of those 4 specific mutations made a significant difference, although the CDKN2A and the PIK3CA mutations, if you were mutated in those, seem to do better, which is something that should certainly be looked at in future studies to see if that's an existing phenomenon that's occurring over and over. With regards to MSI high and tumor mutation burden, unfortunately, the numbers of patients were very small with those. We only had 13 patients, or 3%, that were TMB high. So there really wasn't enough of a group to be able to make any definitive conclusions. And similarly, only 5 patients, or 1%, had MSI high tumors. So again, it wasn't enough to be able to make any definitive decisions. Finally, with regards to PD-L1 changes, we looked at the hypothesis, as I said, that chemoradiation could alter the immune microenvironment. And here we had paired the diagnostic tissue from pre-chemoradiation. So we had the true baseline PD-L1 score before we intervened at all. And then we looked at the post-chemoradiation PD-L1 score. And we looked at that in CPS and TPS. And what we showed was that there was a pretty significant dynamic change in PD-L1 expression at the CPS level, with 51% of patients having a higher PD-L1 CPS score post chemorads. Now, does that make a difference? Well, what we showed was, and again, it was a small number of patients, it was approximately 80 patients. So in those patients that had CPS upregulation post chemoradiotherapy compared to what their PD-L1 score was pre-radiation, we actually saw very interesting disease benefit from the use of subsequent nivolumab with a hazard ratio of 0.30, which was probably the best, disease-free survival benefit we've seen in a subgroup. So again, hypothesis generating, but this is one of the first studies, in fact, in my mind, is the first in a phase 3 setting to be able to show that chemoradiation may alter that immune microenvironment. So again, I think we need to look at that in future prospective studies. Well, I think what we know for certain is that adjuvant nivolumab is a new standard of care in resected patients post trimodality therapy for esophageal and GE junction cancer. So that exists now across numerous mutations. TMB high, MSI high were too small, but again, there's nothing that would indicate that would not be the optimal strategy for those patients if they didn't get an immune checkpoint inhibitor in the neoadjuvant setting, for example, which is being investigated at the minute. We show that the higher inflammatory and proliferation gene expression signature score was beneficial, and a lower M2 macrophage, endothelial, fibroblast gene expression score. So hopefully these gene expression signatures can now be adopted and brought into the mainstream and assessed prospectively in future trials, as we try to move away from just simply relying on PD-L1 to determine who's likely to benefit. We need to keep an eye on whether the CDKN2A or the PIK3CA does result in improved survival. That was a hint here we saw, so we need to look at that moving forward. And then the role of radiation in altering the immune microenvironment. Fascinating hypothesis. We've never been able to show it in a phase 3 setting. Here we showed hazard ratio 0.30 if you had an upregulation of your PD-L1 CPS score. Wasn't so much for TPS, but I think there's a difference between the tumor proportion score and the combined positive score, in that tumor proportion score is more driven by oncogenic changes within the tumor, whereas the CPS score is driven by this, cytokines and inflammatory milieu that can result post-radiation. So it just needs to be looked at in future studies. I think, again, small numbers of patients, so we need to take the interpretation of these results, carefully, and the clinical utility of these biomarkers and the optimal cutoffs will need to be, validated in future studies. But as per the norm for these biomarker presentations, they are hypothesis generating. But this was, as I said, is probably the most robust and largest biomarker data set we have in this particular disease setting. So I think the results are quite interesting indeed.